So if you've been paying attention to some of the news here recently, there seems to be a group out in the Midwest that's looking to not have respiratory therapists on hand at night. And I just wanted to kind of go over a couple of things that, as a respiratory therapist, it jumps out at me. Hopefully it would jump out to somebody else that's going to be managing a mechanical ventilator. I always find it interesting. I work at a facility that does not put respiratory therapists on their air care team for the adult population. So instead, I get to have a registered nurse and or a paramedic round with me for about 45 minutes. And in that 45 minutes, I'm expected to teach those individuals what it's taken me 2 years of school plus a career to learn about mechanical ventilation. Not to say that it can't be done per se, but just want to make sure that try to stress the importance of the respiratory therapist at the bedside. Because as you can notice, now, yes, I'm just utilizing a test lung here as opposed to that mannequin actually being intubated with an endotracheal tube. We do have the bag valve mask set up. It, under normal circumstances, should not be laying in the bed with the patient, so I can point that out. They're also not, we'll have an endotracheal tube artificial airway in place. But for all intents and purposes, let's pretend that patient is ventilating, and this is the patient's room that I'm walking into to take care of. Now, if you'll notice, the lungs are going up and down. Ventilator's not making any noise. So for those that are not trained in all things mechanical ventilation, they may tend to think that everything is smooth sailing with this patient. But I'd like to get a little closer to the ventilator and allow you to take a peek at a couple of things, because in addition to intro to mechanical ventilation, there's a few things that we've been going over in class that I want to make sure that my students are picking up on. So I told you that you've got 3 different types of ventilator graphics as far as waveforms. We've got our pressure time waveform, which we see in like that yellow color on the top of the screen. We've got our flow time waveform, which we see there in the green, or in the green lines in the middle. And then we've got our volume waveform, which shows up in that blue color toward the bottom of the screen. First thing I notice when I walk up, because it's on top and it glares at me, is that, remember, we've talked about peak inspiratory pressure, we've talked about plateau pressure, we've talked about our transairway pressure. That transairway pressure is the difference between your peak inspiratory pressure and your plateau pressure. Plateau pressure gives us a decent idea of what our alveolar pressure would be. And then remember, your transairway pressure, as we've talked about it and explained it, the gap between your peak inspiratory pressure and plateau pressure, we can look at that to help us basically trend that data over time to determine if we've got a compliance or an airway resistance issue. So for instance, if you've got your plateau pressure increases over the course of time and your peak pressure goes up over the course of time, you've probably got a decrease in lung compliance. If your peak inspiratory pressure goes up and your plateau pressure remains relatively stable, meaning that gap between your PIP and plat is getting bigger, there's a decent chance there's an increase in airway resistance. So then obviously the way you tackle those things are going to be different depending upon if it's an airway resistance issue or if it's a compliance issue. And then your knowledge of cardiopulmonary pathophysiology is going to come into play when you're looking to make changes with this ventilator. So when I come into this ventilator, very first question I ask myself is, why is this patient getting a plateau pressure with every breath? Like I said, this ventilator is not alarming. So one would tend to think that everything is all in well. With many ventilators, this one specifically in this mode, you'll notice that we are in volume control ventilation, and it could very well just be the software package that's on this. So not intended to say that every single one of these ventilators, which is the Servo I ventilator, defaults to this as such, because I do understand that the software packages change up. But on this mode, when you activate volume control, there is a T-pause that shows up. That T-pause is an inspiratory pause that is placed on every single breath. Now let me ask you this. When you take a breath in, do you breathe in and hold it for 0.4 seconds or half a second before you exhale? Or do you breathe in, hit your peak and then immediately transition into exhalation? So unless there's a reason for this individual to have that, and there are reasons why you may employ or implement an inspiratory pause in the event you're trying to improve your mean airway pressure, get a little bit better oxygenation or what have you. But under normal circumstances, an individual that's not having issues with oxygenation or so forth, it doesn't really make sense. To turn that on, because that's essentially going to give a breath hold on every breath that patient's going to take. And we can see right here with that plateau pressure showing up on every breath that the patient is holding their breath for 0.4 seconds every time. And if we'll watch the lung inflates, stays inflated, and then it deflates. Probably not the most comfortable mechanism we have for the patient. Another thing that jumped out at me when I hit that additional settings, not additional setting sign, but when I hit the volume control button, notice that trigger right there, -6 centimeters of water pressure. Now I understand that this is a test lung and it's not really gonna generate any spontaneous ventilation, but at -6 with a pressure trigger, we've possibly locked this patient out from being able to trigger the ventilator to give them a breath. So their overall work of breathing could very well be up. Now, I don't have a physiologic monitor on the wall to be monitoring heart rate, blood pressure, things of the like, but I do have eyes and visual inspection, and I can look at that patient to see if they're working as well or not in doing that. So that setting alone right there would make it more difficult for this individual to be able to trigger a breath that they may want over that set rate of 15 that they have. Another thing that I want to point out that jumps out at me when I eyeball these ventilator graphics is if you'll take a look at our volume graphic. With the volume graphic, notice that the inspiratory volume goes up. It's held for a bit of time because of the inspiratory pause that's been placed. And then we move into exhalation. But if you'll notice, that expiratory volume doesn't necessarily make it all the way back to 0 before the next breath begins. If you understand graphics of ventilation, that's a textbook picture of what a leak would look like. So not only do we have a breath hold with every breath, but we've also got a leak somewhere within the circuit, but the ventilator's not alarming. And why is it not alarming? Because chances are, in clinical practice, your alarms aren't set exactly how they're supposed to be. In my program, I teach you that your peak inspiratory pressure should be 10 above and 10 below if you're given the option to set that lower unit. Here, our peak pressure showing ballpark around 27 centimeters of water pressure. That alarm should be at 37, so we're 3 off there. That's fine. Your volume alarm should roughly be 30% above and 30% below. So we're at half a liter on our low minute volume and 40 liters. So this patient's going to have to breathe a significant amount in order for this to alarm to let me know that they're taking in too much minute ventilation. Then if you can remember what an increase in minute ventilation does to your PaCO2, that could very well be problematic if you're dependent upon the alarm to tell you anything. Now, we do have daily blood gases or timed blood gases that we may check on individuals in a physiologic monitor that may clue us into other issues going on. But nonetheless, as is, this patient's going to have to be really bad before this ventilator tells us that there's anything wrong with it. The respiratory rate, we typically set that at 35 and 5. Those are okay there. And then our end expiratory pressures, we tend to go 3 to 5 above the set PEEP and then 2 below the set PEEP when we have that release. That's what we're teaching our students, and always keep the sound level at 100%. So I would tighten those up a bit and readjust that. Individuals that are not trained respiratory therapists may not know that as well. But let's get back to the leak. So if you have a leak, the leak's either going to be with the ventilator, most of the time probably not with the ventilator itself, but with the components that we've placed on there. And do note another thing, this ventilator should have filters, a filter on the inspiratory limb, filter on the expiratory limb. So we should be filtering the gas that's going to the patient, should be filtering the gas that's going back to the ventilator. So that's another thing that I see wrong with this setup. I come back in and make note, we do have an HME here as well. There's the Y of the ventilator circuit, so everything between here and there is going to be dead space. This elbow from the inline suction catheter would be attached to the endotracheal tube going down into the trachea. I would also note at the level of the teeth where that tube is secured at. But if you listen, you can also hear the leak. And if I know you don't have the luxury of being able to feel this, but this is the elbow for the inline suction catheter, and there's a port that should go right there for the installation of saline, should we happen to have saline that needs to be instilled. So that's been broken off. Ventilator is leaking, but not alarming. We've got a tidal volume of 450 set to the patient and an exhaled tidal volume showing a 396. So we're losing volume somewhere, and that's exactly where we're losing it. Take my finger and cap that, and before I just let you watch and see what happens with that exhaled tidal volume and with the ventilator graphic. Oh, look at that. Ventilator graphic, as soon as I covered it up, changed up, and now we're getting much higher exhaled tidal volumes throughout that system as well. So while it might sound like a good idea to let the respiratory therapist sleep at night, if you want to be monitoring ventilation with, make sure that you understand what's going on, because somebody might be looking like they're sleeping well on a ventilator, but other things are going to tell you likewise. So, and I'll change this too while we're here before we close this. So let's turn that down to 0. Accept. And we'll notice that on the very next breath, that plateau pressure is going to go away. So now that patient will be breathing, although it's a positive pressure breath, breathing more similar like we would in spontaneous circumstance. Thank you for your time.